we've done all the math and linear systems and everything you're going to do towards CT. Today, we're just going to discuss uh, an application of CT that I have experience with. That's why I'm going to talk to you about this. I have a lot of experience with doing cardiac CT, and it challenges CT because, the heart's moving, and so you need to do fast images and compensate for motion and things like that. Um, any questions about the uh, physics and engineering of CT thus far? Anybody got any more questions? We've now established. Oh yeah, go ahead.
I think is the process called radon transform, or do you go around and like rebuild the process?
Yes, correct.
Do you do that for a discrete system, like change it anywhere button? Like if we have the 4x4 box,
Yes.
I can take the 0 degrees, 9 degrees, 45. That kind of makes sense where I take one box each. But if I go through a box partially,
Yes.
I think that
That's okay. That's a great question. That's an advanced question. I'm going to repeat it so that it's on here. So the question is, if we're making a discrete image that has pixel dimensions, and we're thinking about the sample in terms of voxel dimensions, let's say a 1 by 1 by 1 by 1 voxel. When I take these projections, as I go down through that array of voxels, my ray will intersect those voxels at different locations inside the square, right? Sometimes it'll just cut the corner of a square. Sometimes it'll go directly through the center of a square. It's depending on the angle. So how does one compensate for that? And the the way that works out is you actually do a weighting function that says for this ray, this voxel will have a certain percentage of that uh, you know signal in it. And so you can actually correct for that. Um, if if you have enough squares, you can usually just do the radon transform in discrete form. And so you just replace all of the integrals with sums, discrete sums. And if you're sampled highly with respect to the object and everything like that, it works out, right? If, on the other hand, you're not sampled highly and you sort of edges come and go in and out of your ray, then that will cause artifacts, right? You'll remember we saw that image where when we looked at the edge, there was all that ringing artifact on there. That's basically from the edge being in and then out and then in and then out of certain detectors, right, as you're coming across. So it does give you some discrete errors, right? As you sample more and more, those errors get smaller and smaller, right? Okay. But in Prince and Links in the book, he writes out the discrete form of the radon transform, right? So you can just look at it, and it's just the way you would discretize any old integral, right? You just do it that way. Any other questions? That's a good question. That's actually like a advanced topic, in chapter 8 or something of She's CT book is like, how do I weight voxels, right? Depending on how the ray goes through it. Do I weight it via the ray? Do I weight it by the voxel? Um, so we've seen this before, I think, and this is a final 3D CT image. The dimensions of this thing are 0.5 by 0.5 by 0.625 millimeter voxels. And the whole thing, as you recall, was essentially obtained in 180 degrees worth of projections plus a little bit more. We didn't talk about this, but the folks who are doing the difference between parallel beam and fan beam CT will probably show us that when you do fan beam, you can't just do 180 degrees worth of projections. You need to sample a little bit more than that to fill in the edges and get all of the angles, right? So this thing takes about 170 milliseconds to get all those angles. And if you are a good planner and you take essentially you put ECG leads on the patient and you watch how you're doing with respect to the phase of the heart cycle, you can pick certain phases of the heart cycle where the heart itself has the minimum amount of motion. It may not have zero motion, but it's pretty quiet. And we'll watch a movie and we'll see where that is. So this picture, we've focused our data acquisition such that we're at that time in the cardiac phase so that the heart's relatively stationary and we don't get huge motion artifacts. And this is without any motion correction, this data. And you can see very small, like this descending vessel here that's coming off the right coronary. That thing is, pretty fine in its structure and it's all resolved. So this vessel is not moving much at the time that we're taking this image, right? So it's really clear all the way down. If we took this image while the heart was in mid-contraction, mid-systole, this would be a big old blur up and down this way because it moves up and down when the heart contracts. It would not only just be a blur, it would be like a cycloid pattern. It's a very interesting motion artifact pattern in CT. So again, when we're thinking about this is the scanner that I always think about because it has this wide detector such that we can get all this information in a fraction of a heartbeat. We don't need multiple beats to integrate up the data as we do with a CT scanner that has a narrow detector. It's cheaper to buy, right? It might be $750,000 or something if it has a 4 centimeter detector. But if you want to image the heart, you have to roll that thing around a few times and move the heart through it, right? And that causes problems. So here's the data you get out of that as a set of two-dimensional slices, a stack of two-dimensional slices, and we're just going from the top of the heart and pushing down. This is the aorta. This is the left atrium. These are the pulmonary veins you just saw fire off there. That is the aortic valve right here. And you can see a very small piece of calcium on this person's aortic valve. So you get this calcium everywhere in the vessels and on the valves, etc. Up here, this is fat. And recall that fat has lower attenuation than water. So the Hounsfield units up here are negative. They're about a minus 100, something like that. This is a vessel filled with contrast. It's the right coronary artery. But the fantastic detail, and this is the way clinicians, when they read these scans, when they read a coronary angiogram with CT, they sit there with the reading box in front of them and a mouse, right? And they roll through it. They just look at this, they roll down through the left like this, and they're watching these bright things take off because those are the vessels going down. They don't go back to this. Like clinicians, you'll never see a clinician sort of, oh, do I have, a stenosis in this vessel using this model, right? The only time they use this model really is if they look at the images and it looks strange. Say, did something screw up? Like did the acquisition screw up for some reason? Like there was a bad heartbeat or something went, and they'll come and look at this model just to look at the image quality. And if something did screw up, you see it pretty well globally, in the features on this. And so they'll just say, oh, this is bad. We should reconstruct an image at a different phase of the heart cycle or something like that. So they get really good at this. They basically can zip down through this data. I'm going to pause it. They just zip down, watch this vessel, okay? They cruise down through that and look at it, say, yep, doesn't seem like it's disappearing or there's nothing bad, untoward going on there. Now we'll watch this right coronary artery come off the aorta here, and it'll go down and around the back of the heart, right? This is a pretty slim RCA, so probably this person has most of the back of their heart perfused with the circumflex artery, because this one looks pretty small, but you can see something happens right there, right? That got pretty bright right there, and so that's a piece of calcium. So they would call it positive for coronary calcium there. They can read one of these in about 10 seconds. They just go through the slices like this, up and down, and then they'll tell you, where the stenoses are and things like that. So one of the things about that coronary calcium is that it has been shown over the last 30 years, there were early believers in this theory that if you have coronary calcium, you have a higher probability of having a heart attack. That was the hypothesis. And after 30 years of taking tons and tons of data, even though it was pretty obvious 20 years ago that was true, finally now the American Heart Association and the ACC, the American College of Cardiology, have said, yes, it's a good idea if you have a patient and you're uncertain as to whether or not they should go on a statin, you should get a coronary calcium scan to see if they have calcium, right? And this is a trivial scan. You don't have to inject contrast. You just put the patient in the scanner, zip, do it in about, tenth of a second, and then you see these bright signals here if there is coronary calcium in that person's coronary arteries. This example, this is 3 different people. Okay, so let me put this person, this person, this person. They're all roughly the same age. They all have exactly the same background risk of having coronary artery disease. That is their age, their sex, their history of blood pressure, high blood pressure, their LDL, and all of that kind of stuff. So they have exactly the same risk, right, from those clinical phenomena. You put them in the CT scanner, this patient comes out and there's absolutely no calcium in their proximal coronary arteries. This person, there's a little bit, right? They've got this one lesion, and this person, there's a bunch. So they have calcium smatterings all over their coronaries. This person has been proven to have a much higher risk of having a heart attack, okay, than this person. If you're totally clean, you've got nothing there, even if you're 65, they'll say you have like a 1% chance of having a heart attack or less than 1% over the next 10 years. Whereas this person probably has 10 times that risk, right? So this person should go on a statin, is the argument. And so that's the most practical, least expensive way to use cardiac CT to essentially help with population, prognosis, make the population better, drop the number of heart attacks. Yeah. It's basically something that happens after you've had some kind of lesion that's repairing itself. So if you have a slight tear or inflammation on the endothelial layer of a vessel, so say I have inflammation and it boils up a little bit, as it fibroses over and repairs, calcium is deposited. And so it's like a history of the repairs that have been laid down in the coronary artery, right? So it's not a cause. In fact, it stabilizes the artery. And so if you see lesions that don't have calcium, that are fresh lesions or it's called low attenuation plaque, that's way more dangerous than having calcium along there. Because the calcium is sort of everything's like patched itself up. It's like its own, patch system. However, it's a history. The more you have, the more events you've had that had to be repaired. And so the argument is like, it's just laying down a history of these small events, right? So this, I think, did we look at the receiver operator characteristic curve, the ROC curve? Can't remember if we did. Um, but if you use this type of image and the calcium score, say a calcium score here would be, say, 400. This person has a calcium score of, is it 10, 100, and this is 0. If you use the calcium score itself, like more calcium and higher score, to put a cutoff and say, beyond this, I'm going to say that person's going to have a heart attack in the next 5 years. So you make that call. And then you look at the statistics. Did that happen or did it not happen? Right. And so if we say, we're going to put our threshold at calcium of 100, right? So this is, we're going to say anybody above calcium of 100, we're going to predict they're going to have a heart attack in the next 5 or 10 years. And then the two rates are the sensitivity of that test. And the sensitivity, if I set it to 100, right, is I pick up 80% of the people that actually went on to have heart attacks, right? So there were some people who have lower calcium, they have a heart attack. I missed them, right? Because I didn't make my test sensitive enough, right? By setting it at 100. So I get 80%. However, I also include down here a false positive fraction, which means 40% of the people who don't have heart attacks, I told them they were going to have a heart attack. So that's a false positive, right? And so you can see there's a trade-off. If I set my threshold even higher, I become stricter and say, I'm not going to predict you're going to have a heart attack till your calcium gets to 400. I only pick up 60% of those people, but I also eliminate a whole bunch of false positives, so 20%. So this curve is called the receiver operating characteristic curve for that imaging test. And all imaging tests, when they're evaluated, you try and get this curve for that test, right? The optimal curve, obviously, the curve would be way over here so that you're up in this corner and you have a very low false positive rate. You don't tell people they're going to have an event who don't have events, and you're going to have high sensitivity. You pick up 80% or like here, 95% of the events. So you'd like to operate over here. All of these colored curves down here are the competing techniques currently used to evaluate risk for having heart attacks. So the big one is the Framingham risk score that was developed out of a long-term study from people in Framingham, Massachusetts. And it uses clinical variables like your age, your uh, triglycerides, blood pressure, all of that kind of stuff. They come up with a risk score, and you go to the doctor and they measure all that stuff and they tell you, you know what, we think you have a N% chance of having a heart attack. So Framingham risk score is this blue thing down here. It's not very good, right? It's not very specific. It doesn't look at the specific things that physiologically are going on to cause a heart attack. Calcium just crushes all of these things, right? So it's way and above the others in terms of what's the most useful thing to know if you want to know, am I going to have a heart attack, right? Makes sense because it's a recorded history of the events you've had in your coronaries, right? So if you've had more events in the past, it's more likely you're going to have one in the future. So what is that event is when you do now have some kind of blister or something inside your coronary vessel and you get thrombus around that as it's being repaired, it blocks off the blood flow. And then downstream from that vessel, you have ischemia and the tissue dies, right? So it's just like cutting off the circulation to a chunk of your heart, and that tissue dies. And that doesn't kill you usually, but what does kill you is if you get electrical abnormalities associated with that tissue dying. So then you start getting strange electrical reentrant loops and things like that. And then finally, you go into what's called ventricular fibrillation, where the electricity, the electrical depolarization is just this random walk of depolarization in the heart, and the heart just sits there. It doesn't beat anymore. Electrically, it's being activated, but in a random way, and it just sits there. And within 2 seconds, you pass out, right? Because as soon as you miss 2 beats of blood to your brain, you just pass out and fall down. Interestingly, I'm not sure this is still true, but 15 years ago, um, the primary sign or symptom that you had heart disease was that you just died, right? Most people had absolutely no, you know, indication that they had problems with their heart up until the point they just died, right? So it's as it's called sudden cardiac death, right? It's like if you have a massive heart attack, you just bunk, hit the floor, and you're gone. Not a terrible way to go, right? But if you're in your 50s, not a great way to go, right? Because all is very inconvenient for everybody who's counting on you. Right? So basically, you know, you'd like to know, do it like, what's my risk here? Should I be on a drug? Should I really go aggressively against this? Uh-huh.
That initial curve, that big, or
Oh, it was done in everybody. No, no, that's as good as medicine got, right? It was done in everybody, right? Until now, a lot of people get calcium scans, but basically Framingham was it, right, for years and years and years. And still would be, it's the traditional thing you do. So here's the Agatston score, it's called, and this is the logarithm. So we're going up in 2 decades here. So as the Agatston score, where you get more and more calcium, right? Then the events go up, right? So this is the histogram of the relationship between that Agatston score and the people who have events, and they're here. And then this is the Agatston score of people who don't have events. So there are people who have very high calcium scores. They just don't have heart attacks. They go all the way till they're 86 and they die of cancer, right? And but the ratio of those people who have events to don't have events goes up as you get to higher and higher Agatston score. And so when you look at the statistics, there's a absolute correlation between those people getting events. Like all of medicine, though, it's just you're still rolling dice. You're playing poker, kind of, right? In that nothing's ever certain, right? In things like this, you basically have a situation you're either going to have a heart attack, not that event count, is dependent on so many variables that you never get out of the statistics of it. But, just like getting good at poker, you get good at statistics, you get better at poker. You get good at statistics, you might get better at predicting who's going to have a heart attack. And one of the things you can do, we did this paper like 5 years ago or something, where you take a 23andMe file, right, for somebody, and it's done with this thing called an Affymetrix 6.0 chip, and it has millions of SNPs on it, right, genetic SNPs. These are individual genetic changes from one person to another, and they're isolated on this chip, this Affymetrix chip, to determine like what are your variables, like where did you come from, historically, blah blah blah. But you can pull out about 150 SNPs off this chip that really, when you add them up together, predict heart disease. So you can look at tens of thousands of people and look for those SNPs that correlate with having heart attacks. And so you can have this SNP done when you're 6 years old, right? Your genome stays the same your whole life. So it's not like you're developing high risk behavior like smoking or getting, not exercising enough, etc. It's just your genetic background. And so there is basically, when you do this genetic risk score, you have people who genetically have very high risk of having heart disease. And you can show that it's interesting. They show from the data itself, because they have huge populations of people who have had CAC scans, coronary calcium scans, You can show that these high-risk people, when you look at the 140 SNPs off this chip, 25% of them will be positive for calcium by the time they're like 37, right? Whereas these folks, basically, if they have a genetic risk score that's uh, low risk, right? It's -2. This was +2. The purple guy was +2. This is -2. That group, they only cross the threshold of 25% probability of calcium until, after 50, right? So those people, so the question is, who should you scan? If we took all of you and scanned you with a calcium scan, like virtually one person might be positive, right? If they were unlucky. But so screening you doesn't make sense because we're going to have so many negative scans. So what you need to do when you do screening is you need to look at a population that has a certain possibility of being positive and screen those people, right? And that 25% is a pretty good threshold. So you want everybody that shows up in your line to get this screening test, you want at least 25% of them to be positive. That's worth screening. If only 0.01% are positive, you're kind of wasting resources, right? Just getting negative after negative scan. And so this is a way to sort people into when you should get your first calcium scan, right? Is just use their genetics. Here's a coronary angiogram from CT. And this part of the vessel over here is the left main. It comes right off the aorta. It's a big pipe. It's 4 millimeters in diameter. It's coming off. It's going to break off into this that is the left anterior descending coronary artery that goes down the front of the heart towards the tip. And then this one takes a hard right and goes around the back of your heart. It's called the circumflex, and it's going to perfuse the back of your heart. This person has a lesion right here, right? So you can see it indents into the vessel. It also possibly has what's called positive remodeling, sort of something outside the vessel, and it's got this little chunk of calcium in it. It's a very small piece of calcium because it's not very bright. So it's being averaged with non-calcium around it to give a signal that's not so bright. If we look at the cross section of this, so here's A, this is a 3D image, right? So we're gonna cut a cross section down here. We look over and we see, okay, here's a nice big old vessel right here. It's probably 4 millimeters across. This stuff is fat, remember, -100. And then we'll look through this part and I see, well, I still have a wide open vessel. There's lots of space for blood. I have a lesion that looks like it's positive remodeled. It's a little bit big, and there's a piece of calcium. When we get into the LAD, the thing closes down by a factor of 2. So it's sort of like 50% smaller than it probably should be at that point. But so be it. If we look at this section right here, right after the lesion, here's the cross-sectional area of that vessel. Now that's starting to get concerning, right? It's now it's stenosed down more than 50%. It's probably like a 60%. However, this person, they're still jogging, riding their bike, doing this, and they don't feel anything, right? Because they don't have enough perfusion deficit to generate a symptom like pain in their arm, pain in their neck or jaw. They just are chucking along with this thing in there, right? And here's a example of high resolution imaging of coronaries. And this is, remember when we were trying to decide what resolution should our detector be? This is the Toshiba scanner that doubled basically the resolution. And we'll come back and take a look at a couple of features here. As we cut down, bing, you can see that tiny little thing there got really bright, right? Because it's now isolated into a smaller volume inside this voxel. So even though the vessel is still big, you can see absolutely clearly that there's calcium there. Go back here. There's all these pieces of calcium on this person's aortic valve, right? Again, as we looked at this person before, low resolution, and then this small RCA out here showing that the person is probably left dominant. That means what left dominant means is that this vessel, this one here, that's going to go around the back of the heart. So we'll watch it, see it shoot back around here underneath the left atrium, and it's go to the back wall of the heart. That vessel is primarily how the back wall of the left ventricle is going to be perfused, as opposed to this one, which is too bad, right? Because that means if this vessel goes down, this is the left main. So say you have some kind of thrombus in there, that means you cut off the anterior wall of the heart from the LAD, and you cut off the posterior wall of the heart from the circumflex artery, and you're toast, right? Yeah. Yes, you can be left dominant or right dominant. And so what in embryology, when you're growing in the womb and stuff, you have both systems are quite big, but then as time goes on, one of them fades out and the other one dominates, right? It's a missed opportunity for humans to be more robust, and that you should have them both full, right? Because why not? It's just a parallel system of blood. And then if one goes down, you have this backup, right? So ideally we would have that. Dogs have that, right? They have a lot of parallel perfusion in their heart. Pigs do not. Humans do not. Uh, That's just true. You're either left side dominant or right side dominant. Yeah. Well, I don't know. There are people who have wide open circumflex systems and wide open RCA systems, and they're lucky people who don't die from heart attacks. Yeah. Right. Um, yeah. And then the other wasted thing is that we have this cusp here. You know how the aorta comes down and then there's the aortic valve and there's the root of the aorta and it has three bulbs, right? Because it's got three aspects to the valve. And then two of those bulbs, vessels come off. The cornea vessels come off of two of them. The third one, nothing comes off. It's like, there's a missed opportunity. Like, we should have another vessel coming out of that thing, right? Does it just for symmetry, right? But it doesn't. And then in some people, one of the vessels, like the RCA, doesn't come off that. It actually breaks off from the left one. You have these strange, you know, uh, vascular abnormalities. So here's a really big vessel, tiny piece of calcium. This is an image of that previous lesion we saw in that patient on a high resolution scanner. So you can see that it's better resolved here. So this has, uh, as we said, a 0.5 millimeter detector, so doubled the sampling in the detector direction. And the spot size on this scanner can go down to like 0.5. So you have a small spot size. So this person's also small enough that they can use that spot size. And here's a direct comparison, same person in the high resolution scanner versus a lower, sort of more classic scanner, where you see it's a lot blurrier here. And I think I have here, we're trying to get the same plane cut in a standard scanner with the 1 millimeter detectors and the 0.7 and 1 millimeter spot size versus this high resolution. So you can see the difference there, right? It just looks like it's been smoothed, right? It's blurrier versus here. You're going to need more x-rays on this side, right? There's no way around that. If you have 4 times as many detectors, you don't need 4 times as many x-rays, but you need more, right, than over here to get the same signal to noise. The other interesting thing about calcium scanning right now is that because it was started in sort of the late 70s, early 80s on these specialized scanners, those scanners had a slice thickness of 2.5 millimeters, which in 1981 seemed like a really sharp, small slice, 2.5 millimeters, right? Uh, and in this patient, this is exactly the same raw data reconstructed with slices at 2.5 millimeters. And then that's on this side. And then on this side, reconstructed with slices at 0.625, right? So four times narrower. So four of these slices here make up one of these. And here you can see we get a positive calcium signal in this artery. Definitely that's calcium. It's not just noise. And over here you just miss it, right? You just don't have the resolution. The slice is too thick. The piece of calcium is small in there. Until you get down to a thinner slice, you don't see it. So this person gets called negative for calcium if you do the standard imaging. They would get called positive here, but their calcium score would be really small. It would be somewhere between 0 and 1, right? Whereas your calcium score can get up to 1,000, this person clocks in at 0 for this 2.5 millimeter slice. This histogram gives, if you look at a large clinical database where they have people of all ages and they look at the calcium, the frequency of calcium scores, here's 1 to 10, 100, 30 to 70, 70 to 150, 150 to 310, 310 to 600. So it's going up sort of logarithmically. And and that's the number of people that have that calcium score. And then this is the number of people that have a calcium score of 0. There's a bunch of people in here who, when we scan them 5 years from now, will not have a calcium score of 0. They will have enough calcium to actually be seen on these images, right? So the question is, how many people are in the box between 0 and 1? Because that's not measured anymore, right? Well, it never was. It is not measured. And so I think as engineers, for us to make better pictures, we can find the people in here who are destined to come out here. We'll find them earlier, right? Yeah.
Just linear to like the number of calcium positive pixels? Does it like care about grouping or
Right. So the question is, it's a very good question, and I should have put a formula up here before I started. What is the Agatston score and how's it computed? Is it just linearly proportional to the number of pixels that have a high enough amplitude that they'd be calcium? And the short answer to that is no, it would make sense. I think the score you just described makes more sense than the Agatston score, which weights the pictures based on the Hounsfield units of the calcium. So if I have a bunch of pixels and the Hounsfield units in those pixels are 160, they're above a specific threshold, which is 130. So that counts them in. And then you multiply them by their actual Hounsfield unit. So if they're 500, your Agatston score goes up. There is no evidence that a higher Hounsfield unit piece of calcium is more dangerous than a lower Hounsfield unit piece of calcium. So that's kind of a screw up in the formula, right? But it's been with us for so long, and all of this data has been taken for so long that that's how it's still done, right? If you look at the fraction of people in the population who have a calcium score greater than 0, that means that you detect any calcium. 10% of people between 34 and 44 have a calcium score greater than 1, right? And then it gets to 25% of people 45 to 55. And then it's up to almost 50% of people greater than 55. So traditionally, people don't get calcium scores until they're in their 50s, because then you have a 50% chance of being positive, and that's usually the way it's done. Yeah.
do people have an event and have a little calcium? Is it, or is it like one drastic event, like jumps?
Yeah, so there, I guess there's a couple of questions there. One is like, is there some kind of fine structure in here between 0 and 1? There would be, but it's hard to measure because we don't have that resolution. Calcium starts out as microscopic pieces of calcium, right? So you can measure it all the way down to these very small numbers. But as we go up here, this is as the Agassiz score goes up and the calcium score goes up, it's basically an integration of a lot of small events is what it is. The final terrible event that, is fatal doesn't have much to do with calcium, to tell you the truth. It is mostly the endothelial layer of the vessel gets damaged enough to cause a cascade of events that cause clotting to try and repair it. And then that causes a thrombus in the vessel. And then that's the event that the blood gets shut off, acutely, and that causes the fatal heart attack. So there's the question here is like, if you're in this genetically high risk group, you're in your 30s, or say you're 30, you're 35, I have a 10% chance without doing any genetics. If I do my genetics and I have a 30% chance, should I go and see if I have a calcium score of 1 or 2 or something? And my feeling is you pull these people out, you get them on statins early, because what's been shown with statins is it's your lifetime exposure to LDLs that give you your final risk at a certain age. And so you really want to try and reduce your LDL over your whole lifetime, right? And so there is some argument to, well, why spend money on imaging? Why not just give everybody statins, right? And the issue there, up till 5-10 years ago, was cost, because they were very expensive. So Pfizer and all the big drug companies made a lot of money, billions and billions of dollars selling statins. But now you can get it for 30 cents a day or something because it's off patent, right? So why not give it to everybody? Problem is there's side effects, which give people sort of similar to muscle cramping, and it's kind of a chronic pain, like a muscle cramp, and it's you can't live with it, right? So they stop taking the drug, right? So you don't want to give it to people who don't need it, right? In terms of radiation dose for looking at the coronaries, like, is that a concern? If the patient is small-ish, you can get remarkable images for very low dose. So this is off the GE scanner, and you get these great vessels showing that this person's negative for coronary artery disease up here, and this was done at 0.28 millisieverts. And remember that the dose you get just by being alive and walking around is 3 millisieverts a year. So it's 1/10 of the background dose for this. And so really, I don't think the radiation risk is a big factor, especially for people who are, beyond halfway, like beyond 48 or something like that. The other thing is, even if your heart rate, this used to be Achilles heel of CT, was if you had a fast heart rate and you needed more beats, right, to acquire your data, because it took a long time to get the data, you would get all of these problematic motion artifacts. But now with these big detectors, we're scanning people over there at the hospital now, even higher than 90 beats per minute. And it took a long time to get the techs and the physicians to just relax about heart rate. If they had a patient like this, they would give them more and more drugs to try and bring their heart rate down, right? Metoprolol and stuff like that to bring the heart rate down. But with the technology we have now, it's basically achievable getting good images even at these high heart rates. Not only that, because we only need one heartbeat, if they're in atrial fibrillation, which a lot of cardiac patients that present can be in atrial fibrillation, and what that means is the electrical depolarization in their atrial tissue is in fact random. It's just rolling around in a random pattern all the time. So their atrium just sort of sits there. It fills passively and then shrinks back down. It doesn't really contract ever. That's called AFib. And those patients, their heart rate is random, right? So the time between one QRS and the next QRS is a random number, right? Around some mean. And so when you're trying to organize, how do I how do I take my images? If you need multiple beats and they're all in these different, you know, periods here, you're kind of screwed. But we just need one beat. And so now that the darn scanner spins that fast and it has that many slices, we can do the whole thing in one beat. So you can do AFib patients. So here's an example of an artifact that occurs when you're sampling or you know, your detector is only like 4 centimeters or a few centimeters like this. This is that Siemens scanner that has the 2 detectors and the 2 X-ray tubes. So you can go fast, but you still need multiple heartbeats to fill up to measure the whole heart, right? Because your detector is only this thick, right? So when you project the heart down, you don't see the whole heart. So you have to move the damn detector along, right? And what happens, uh, this is Word, man. Hang on. It'll work here. There we go. Okay, look at this one here. Do you see that coherent 4 centimeter thing like floating up through the heart? That's actually a picture of how that detector is rolling through the heart. And on either side of it, that's a beat before and a beat after. And you can see that thing is rolling up. That heartbeat was quite different. The walls are in a different position. You know, the rate at which the thing was beating is different. And so this is called step artifact. And if you're going to do cardiac CT, my personal belief is don't use these scanners that have these thin detectors, because when we look at 100 cases and here about 15 out of 100, it depends on the group of patients, but a lot of patients have these step artifacts, right? And it's because the heart rate is variable, right? And so we mostly go for the big detector, you know. Yeah.
Yeah, or is it better not to?
That's a great question. So, could you, if you knew what was going on here, correct this data to get rid of this step artifact? In certain instances, yes, you can correct it. And it involves a lot of interpolation between, you know, what is on either side of your detector. And Siemens came up with a product and they call it Z-free. And it's basically they go in and post-process this data to try and realign everything, right? Because it's such a problem. And you can imagine if you're looking at, I don't have an example here, but a coronary vessel, the vessel will come down like this and then just jump over here, right? And it'll be a different part of the coronary and then it jumps back over here. So they try and patch all that together. I don't have enough experience with it to tell you an answer, to give you an answer. We should get a moving phantom, right? And precisely know what the correct answer is and see if it can correct it. Yeah. Yeah.
When you get a CT scan, they do your pulse oximeter. Is that like related to the acquisition or like finding something? Or
Yes.
like secondary?
That actually, the pulse oximeter. So the question is, when they give you a pulse oximeter when you get a CT, is that related to how the scanner is triggered? Yes, it can be, because obviously it's a filtered, smoother signal than your QRS, but it is related to your QRS, right? It's sort of when that thing peaks, that's the peak blood flow, so it's after end systole, so it's phase shifted with respect to the QRS, but it's still marking a position in the heart cycle. And so you can use that signal to trigger. You just have to shift your time delays to compensate for the fact that that signal peaks at a different time, right? Um, then the other thing is like it's just good to know your blood oxygenation, right? Just you're getting some contrast. If you have some kind of allergic reaction to the contrast, it's good to have some stuff on so they know how you're doing. Yeah. Okay. I think I can go back to this. Yeah. Okay. Now the other advantage of cardiac CT over echo and um, MRI is you can have something like this in the patient, right? And this is a HeartMate. It's a left ventricular assist device, right? It's a lot of gizmos, right? There's a lot of machines in there, a lot of motors, electrical stuff. So you plug this into the back, basically the apex of the left ventricle. This is like a suction tube here, and it sucks the blood out of the left ventricle, and then you would plug this into where you want it to go out, and so it's an artificial heart, and it can be running and everything, and here's your CT image, right? So you have the patient plus a pretty decent image of the device itself, right? Whereas on MR, you don't even put them in there. And on echo, you're getting all these crazy, echo stuff off the metal. Yeah, they do. Yeah. There's oftentimes it's oftentimes used as a bridge to transplant. So if you have heart failure, and that means what profound heart failure means your left ventricle just can't contract anymore, right? So it's just not pushing blood. You plug one of these in and the person's on a transplant list and you just hope that a donor comes along before. You can live on this it depends on the person, but for quite some time. Usually you don't walk around with it, like, go home and a year later come back and check on it. It's not that kind of device. No, this one's got a little propeller kind of thing right here. This guy right here. So it sucks blood out of the bottom of the left ventricle and then pushes it out the aorta. So the big deal about these pumps is that when you have a propeller like that, it tends to break up red blood cells and it causes problems. But it's still an ongoing business that's, as you can imagine. Okay, it's our time here. We got about 20 minutes. So it has been essentially established without a doubt that if you, even if you're a person not of high risk, but if you're a person of high risk because you have high LDL in your blood, when you go get your blood work done, if your LDL is above 120 or something like that, it's been well established that if you go on a statin, your probability of having a heart attack goes down, right? And in fact, if you have an LDL of say 180, so a high LDL, and if you bring it back down to 100, your risk goes back down to basically normal, like what people with an LDL of 100. And so these are great drugs, okay, these statins. 20 years ago, maybe 30 years ago, some faculty at the medical school of Stanford got in big trouble because they, in a lecture, said, this data tells you that statins are a fantastic drug and they work, right? This is at the leading edge of finding out that statins work. And the medical students found out that one of the faculty or both of them or something were on a speakers bureau for Pfizer or something like that. And they went bananas. And they had a big demonstration that these faculty were corrupt and this information was bad. They work. So it's like, it was pretty obvious from the data they work. So if you're young, but if your parents Like, oh man, my doctor says I should go on Lipitor. It's not a bad thing. You should do it. If uh, if you can not get side effects, it's a free ticket to lowering your risk for having a heart attack. It's great. Um, so that was established. So there is a thing you can do when you find out somebody has high risk of having a heart attack, right? And so that thing that we looked at before, the Framingham risk score, 10 years ago was updated to be a more sensitive, more accurate risk score. And this is called the ASCVD risk calculator. And, it has multiple things in it about blood pressure and previous disease, et cetera. But it's all clinical information. And so the question, this was a really cool paper. The question was, well, let's take, this risk calculator and decide who should go on a statin and who should not. Okay. And let's image them and see how that correlates, like with our decision using this risk calculator. Sorry. Okay. So in one group of patients, 30 out of 131 of the patients in that group who were found to have absolutely no coronary disease on their CT. So these are people that are stone cold normal CT, like big wide open vessels, nothing going on, right? No calcium, whatever. 30 out of 131 were recommended using this risk calculator to go on a statin. And that probably makes sense because they had high LDL, right? So that's probably what drove them to that recommendation. And so that's okay. Then this group of 68 patients who were found to have non-obstructive CAD. That means on the cardiac CT, you look at it, they have lesions. They've got calcium, they've got lesions. It's non-obstructive though. So it's not a tiny lesion that causes symptoms, etc. So those people have heart disease. They've got calcium, they've got lesions in their coronaries, right? Using this risk calculator, only half of those people were recommended to go on a statin, which is crazy, right? If you've got coronary disease happening, you should go on a statin. There's no question, right? And then the group who had ridiculously bad coronaries, like the coronary went down to 5% or whatever. It was like a terrible lesion. You probably take them to the cath lab. 13 out of 20 were told they should go on a statin. 7 of those people were told they didn't need to go on a statin, right? So it's basically, from my perspective, the engineering of imaging has overrun these risk calculators that are based on just clinical measurements, that aren't based on, do you have coronary disease? Are your vessels, getting smaller from coronary disease, right? And so this is where imaging, I think, should change the way this process of deciding, like, what is the long-term goal for my patient. So here's a study that was done about, it's 2015, so 10 years ago. So the data was collected, say, between 15 and 10 years ago. So it's kind of early CT data, early in the sense of these wide detectors were just available as this got started. And this is a heroic study, really big study. And the question was, should you give someone a CT scan as soon as you think they have cardiac disease, coronary disease, what should you do? Should you do what we do now, which is a nuclear medicine scan, right? Or should you do a CT and roll that way? So it was like head to head. How does this go? And so this is my own little cartoon of this study. You start with a lot of people, right? Almost 5,000 people in each group. Each one of these groups is identical in terms of prior risk, like as they come in, what their risk profile is. In half the people, we're going to do our traditional nuclear medicine stress test, okay? In half the people, we're going to do coronary CTA right out of the box, right? Which is not done. At this time, this is not done, right? So what happened? So the group that went for the stress test, out of this 4,692, 406 were found to be positive enough on the nuclear medicine stress test to recommend they go to the cath lab. And remember what the cath lab is? When you inject the dye straight into the coronary and you get those ridiculously high resolution pictures of the coronaries. That's kind of the ground truth in this whole thing, right? So do you send someone to the cath lab? So 406 got sent to the cath lab. In the CTA group, same risk structure and everything. After the CTA, 609 got sent to the cath lab. So we have a big difference already in the behavior of those two groups in how the healthcare system is going to, you know, what do you do next with this patient? So there's a big group here missing that's over here, right? And they're in this box, this, people that were negative on this test. Two of my good friends weren't in this study, but went through this. They went through this stress test thing and wound up in this box, right? They had a negative nuclear medicine scan. Both of them knew something was up, right? Because one was a cyclist who used to cycle a lot, and he all of a sudden couldn't keep up with the group. His performance was going down. It's like something's going on, right? And but anyway, they do a stress test. It was normal. He got thrown in there. So what happens next? These 406 that came out of nuclear medicine were sent to the cath lab. And so let's see like what the ground truth is. Who has disease, who doesn't? 213 of the people that were sent to the cath lab were stone cold normal when they got to the cath lab. So basically, nuclear medicine said, this person's got the disease, send them to the cath lab. When they got there, vessels open, no disease, right? 193 actually had disease. And of those, 120 got stents and 38 got basically bypass surgery. So if you have a lesion way up close to your aorta, usually they just bypass it. They don't try and put a stent too close there. Over here, of the 609 that were sent to the cath lab, when they got in the cath lab and they looked, 439 had coronary disease, right? Let's compare this number, 439, to this number, 193. There's a few people missing over here. Right? You've got so many more people with coronary disease here. 236 stents versus this. It's twice as many stents got put in, twice as many coronary bypass surgeries got done as this group. Otherwise, those two things are identical, right? So you treat twice as many people on the left side, right, when you do the CTA. Is that good news for an insurance company? If I'm running the algorithm, I'm the insurance company, which one's a better pathway here? It's not a trick question, right? So basically, this looks like you're going to do more medicine. Like when you dig in and get these really good pictures, you're going to do more medicine, right? We as engineers, yeah, let's see. There's obviously a problem here still, right? And that is of these 609, 170 were normal in the cath lab. So we have a problem on this side that they went into the cath lab and they're normal, and then that's an issue. We need to make better pictures so that this doesn't happen, right? And when you're really reaching, you would say, of the 439, only this many actually got treatment, right? They were abnormal, but there was a chunk here that they weren't abnormal enough to either do a stent or a bypass, right? They're over here. And so ideally, we make the pictures even better so that when you get this group, you would say, we know this is abnormal, but we also know you're not going to do anything. You're not going to do any treatment. So there's no point going to the cath lab, right? So that's where we come in. The engineering group comes in to say, we're going to make the pictures even better. The final conclusion of this study, after it was all said and done, and it's in the last paragraph of the paper, and you can read it, was that these two approaches for diagnosing heart disease are equivalent. And the reason they were called equivalent was that the number of people that died on this side was the same basically as the number of people that died on this side in this trial, right? And part of that is there wasn't really a huge difference in the number of people you treated, right? So to detect that difference would be kind of hard. However, it's remarkable to me that the conclusion of the paper was, oh yeah, you can do either one of these equally, right? They're fine. So question now is that we're going to address here is like basically when you're looking at screening of a population, right? Is it appropriate to screen people for heart disease, right? So screening, let's remember what that is people who are being screened for a disease are people who walk in, they don't have symptoms, right? It's not like it's not a response to their symptoms that they probably have that disease. These are people you just take off the street and you image them. And this is done in breast cancer, for instance, right? You're recommended by the time you're 40, right? You should have a mammogram, and that's screening. You don't have any symptoms or anything. They just image you right out of the cold, right? So this group, this is the Agency for Healthcare Research and Quality. It's part of Health and Human Services. Evaluates the literature and makes a recommendation regarding screening. And so they would recommend about breast cancer and mammograms. They recommend about CT for lung. For people who have been smokers, it turns out if you have a CT of your lung, they'll find cancer and you'll have a lower probability of dying than the group that didn't get the CT. Stuff like that's been established. This group doesn't recommend screening for heart disease with any technique. They say you shouldn't screen for heart disease because what it will lead to is overtreatment, right, and harm. So that's their feeling, is that you're going to uncover stuff that looks like the patient has heart disease, and you'll overtreat that patient. It'll be expensive and it could lead to harm. However, there's a caveat to this whole thing. At the bottom says, okay, we think that, should be made on a case-by-case, but a careful discussion of the benefits and harms of screening with the patient. Reasons to consider screening in an individual patient. So what's the difference? These guys are trying to figure out what you should do for a whole population, right? Do we screen the whole population? That was their question. And then this is reasons to consider screening an individual patient. It says select occupations, such as pilots, where sudden incapacitation or sudden death may endanger the safety of others. So you should screen those people. Because, why should you screen them? Because you will find disease in some people, right? So this is the interesting thing about modern medicine, is that deciding what you do with a population versus deciding what you do with yourself is a completely different game. You're playing a different game, right? So they have stated here, if you screen someone, you will find stuff that you should act upon, right? On occasion, that's going to happen. And if the person's really important, we should screen them. Who's important here, right? It's like, okay, I'm driving my car. I got my kids in the car. Who's the pilot, right? So it's a different game, right? It's like, yeah, if it's you or your brother or your sister or your family, you should screen them, right? Because you'll find stuff that you should act upon. Now, you can be led down a pathway where you find something and maybe you shouldn't act upon it. This is where the the issues come in. It's like, should we just leave it or should we act upon it? The thing about heart disease is there's no question you can act upon it. You just go on a damn statin, right? And max that out to whatever you can achieve, and then that's worth the outcome of that screening, right? So here's a coronary vessel in a a patient where you can see that there's like a 50% stenosis. It starts out here, at this distance, it's like 4 millimeters. It goes down to about 1 or 2 millimeters here. Cut it along this purple line, look at the orthogonal projection of that vessel, and it's narrow in that direction too. So it's a symmetrically narrowed vessel, right? And then you cut right through that narrowing here, and here's the cross section of the vessel, and that green line is 1 millimeter. So the issue here is like clinicians, when they look at this, they never take a cursor and measure the dimension of the vessel, right? Because they basically just stand back and look at it and go, that's about a 50% stenosis. They categorize the vascular disease in these boxes like mild stenosis, moderate stenosis, severe. Just put it in those three boxes, right? They never come in here and say, this is a stenosis of 0.95 millimeters divided by 4 millimeters, right? And for good reason. And do you remember the point spread function of CT, right? When we characterize it with full width at half max, right? So I've got a blob that has a full width at half max. So the point spread function of this imager is about 1.2 millimeters. That's the full width at half max. As something gets smaller than that, the shape of that thing doesn't change, right? It still has that 1.2 millimeter full width at half max. As the object underneath gets smaller and becomes that little bead that we were talking about, it can get really tiny. It still will look like it's 1.2 millimeters in diameter. And so for this stuff, we're working right at the point spread function limit to quantify how big something is. And it turns out that a clinician will look at the picture and evaluate the severity of the stenosis, not only on the shape, but also on the brightness. So as it gets smaller than the point spread function, it gets dimmer, right? The contrast that's going through there might have here, the Hounsfield unit might be 350. And then when you get through, if this got much more narrow, it would drop to like 300, then 250, and then it would just stay the same size though, because our point spread function, we run out of resolution, right? So we're working on the hairy edge when you look at trying to quantify numerically a stenosis, right? That's really small. It says 13. I got 7 minutes. So this company, this is a really interesting company, HeartFlow. They take anatomical models from the CT. They look at how much tissue is there, so how much blood is required, like more tissue, more blood's required. And then they'll run a computational fluid dynamics simulation of the blood flowing through this CT. They build it. And then it comes up with a report that says, okay, as I go down the vessel, the pressure in that vessel is going to drop to 0.87 of what it is here across the lesion, right? And so as the lesion gets tighter, that pressure drop gets bigger. And when you do this with a catheter, you can put a really small catheter in here, measure the pressure here, proximal to the lesion, and then you push it across the lesion and measure the pressure there. You will see the pressure drops, right? And what was shown in a number of trials, like the FAME2 trial, was that if this pressure drop is more than 20%, if it's more than 0.8, then you should put a stent in this thing. And the reason you should do that is if you don't do it, people wind up back at the hospital and they get the stent anyway. So that's the threshold at which you put that stent in. And this technology basically does that measurement from the CT, as opposed to putting the pressure catheter in that person's coronary artery. You just do the CT and do this computational fluid dynamics and figure out whether or not they need a stent. Yeah. So the question is this automated? And early on, the answer to that was no. Somebody went in and manually guided the segmentation of the artery such that it was to the best of their abilities correct. Okay. Now, the business model for these guys was you load your raw data, which is a CT image, load it up to our site, our company, and it goes up, and then we segment it and we come back with this report. So they now have hundreds of thousands of cases in their database. So what do you do with that? Right? You just train a network, and so now it's their turnaround time now is very fast because they just run a network on it. And you could teach a network to just pull out these pressure numbers, right? As opposed to doing segmentations and all that, just, do from soup to nuts, right? So you don't have to do any computational fluid dynamics or anything. Way cheaper, way faster, and they have the data to do it. So it was really smart. And it gets done every day, I think, in our place. And the thing is, like, here's that lesion on the angiogram. So you can see it does narrow down, right? Let's stop it here. So it is narrow. It does kind of fade, right? But it's not enough. That 0.87 isn't enough to warrant putting a stent in there. And so you don't put a stent in this case. You just give the person the best drugs you have. And it turns out that lesion has to be really severe. If they're stable, it doesn't really matter if you put a stent or not. Drugs or stent, if they're stable, both work out about the same. That's been shown about 2 times now in big trials. However, if a person shows up and they have pain, they have ECG abnormalities, you should put the stent in, no question. Yeah. Oh, well, they were at it for, I would say they have somewhere between 50 and 100,000 cases probably in a database. I don't know. They'd probably tell you, but the deal is they have all that data, right? So, and you had to, in order to get the product, you had to agree to ship it up, and then just the report came back. Okay. And so here's a case where, it gets a little more narrow. It's at 0.78. So this is it's a pretty cool product. Okay, we'll do one more thing. If you can make a scanner that has high enough resolution to see fine details of coronary lesions, you can start characterizing lesions like this. I have a vessel here, not a big stenosis here, but it has what's called positive remodeling. The lesion is growing on the outside of the vessel. That turns out to actually be a risk factor, a higher risk factor if you have this positive remodeling. Here's a bigger lesion. It has calcium in it with some positive remodeling. This is a really cool thing. This is called a napkin ring sign, NRS. And here's the vascular lumen that's still open. You can see that there is out here, there's positive remodeling, and then there's this dark signal right here. That dark signal actually is thought to be lipid, right, inside a lesion. And so that lipid-filled lesion with a sort of a fine cap between the wall and that is a very high-risk lesion. And so if you have a system where you have the point spread function and you can use enough radiation to make pictures of this quality, where you like look at tiny little spots of calcium, this kind of resolution, then you can look at all of these plaque features and add that to the risk score. And so you add it to what's their calcium score, et cetera. And so you get a finer and finer prediction as to whether or not they're going to have a heart attack. So that's where we are now. All the vendors are trying to make what are called photon counting machines with very small detectors, so that you can make better and better pictures to do these risk calculations.